Hello, Dr. Garbo.
Hello, hello, how are you?
Thank you. Uh, Thank you for agreeing to present
Th-
your experience in CTOs. Dr. Garbo is one of the most experienced operators in Europe. And we are here with Professor Gelev, Dr. Sianos, Dr. Gurgu, and Dr. Ayub as a panelist. So we can start.
Yeah, thank you. Yeah, first of all, thank you very much for the invitation. It's a great pleasure for me. And I would like to say hello to all these friends you have in on site. So I'm sorry that I'm not able to be here, but we hope to come back next time. So let's start with the presentation. Can you see my slide? Okay.
Yes, everything is fine. Everything is
Perfect.
fine.
Perfect. So we have to talk about antegrade wire escalation and ADR, but the most important concept is the modern approach to antegrade CTO PCI. As you can see in this slide, the antegrade wiring is a fundamental of CTO PCI. This is a pyramid that everybody knows this picture is a pyramid of what can we expect when we are doing CTO from the more easy to the to the most complex. So we need to know all these strategies, and the anti-gate wire is the base of this pyramid. And we know that looking the complexity of our CTO, the integrate success is really high, and the overall success is high. When you go in the most complex scenario, this is are the quite old data of JCTO score. You need more complex strategy. You can see here in the grid. So if you go from JCTO 0 to 5, you need to be able and flexible to work in many different strategies in order to achieve a good success rate. We need to talk about anti-gate wire escalation. So what is anti-gate wire escalation? Normally is starting with the low tip load polymer jacket wire like XTR or XTA, go upgrade your stiffness with the Gaia family, so intermediate tip load non-polymer jacket wire, and then you need to go with the very high tip load guide wire like Confianza, Hornet, or Astato. This is normally what we can say about anti-wire escalation, but this is an old concept. So in this concept, you need to increase continuously your wire stiffness in order to increase your penetration force and more or less try to stay in the to have a intimal tracking with a very stiff wire. If you go on to the modern concept, and is the key of this presentation of this our approach we have nowadays in CTO PCI, we have to think about not only anti-grade escalation, but think about anti-grade wiring. So anti-wire is escalation, of course, sometimes, but even more so de-escalation, use of intermediate tip polymer jacket wire, and take advantage of the whole vessel architecture, improving safety and efficiency. So this is a very important concept because safety is a paramount importance in our CTO PCI. Doing that, we need to understand wire characteristics. So we know that new intermediate tip load polymer jacket wire like Gladius EX have a great torqueability, great good torque response, and they are excellent first choice in a wide range of cases. So they are extremely safe wire, and they never exit the vessel architecture. And this is really important. You can see in this cartoon, we have an ideal tracking in the CTO body, or we can go subintimal, but with the intermediate polymer jacket wire like Gladius, we will never do like that. So we will never do, we will never exit outside of the vessel. So we have we cannot have a perforation in the main vessel. So polymeric wire are not enough for all cases. We can have many studies that show that the success is with all polymeric wire is like 60%, but are enough to start any case. And we can think about stiff wire limited to calcified CTO after polymeric wire failure, or to cross really short segment. In this situation, of course, we need stiff wire, but we need to think about escalation and especially de-escalation. In general, polymeric guide wire are safer and safety is a paramount. And we know that with the introduction of the Gladius family, they represent really a major breakthrough in the modern approach to antegrade CTO PCI. When you have a failure, that when the wire goes subintimal, we need to think about parallel wire technique or ADR. So this is an example of some years ago of Austral LED CTO. You can see here the ideal situation for dual lumen strategy. I puncture, I check with the IBUS. This is a very good IBUS guided puncher. You can see in the middle at 10 o'clock we have the proximal cap. And then even if I puncture very well, the Gaia second was subintimal. At this point, dual lumen in the LED, parallel wire technique, this is a Gaia third. So this is an anti-wire escalation. So this is a step up with Gaia third. And I was able to have success to cross successfully the Ostial LED CTO with very good final result. If we go to the second step of the presentation, we have to think about ADR. So what is the current scenario of ADR? This is a paper of our data of progress CTO registry. So the last 15 years, we can see that we have, considering primary ADR use, a huge decrease of the use of ADR in the last 10 years from 60% to 10%. And what is the reason for that? So the reason is that with the primary ADR in all cases in the US, they have seen low technical success, low procedural success, and higher in-hospital MACE. So how can we improve the modern approach to ADR? We have 4 key points that I can consider in my mind really, really important. So the first one is hematoma management. The second is the use of a modern device like recross for ADR. The third point is to use IBUS for IBUS guided ADR. We know that now we every day we talk about tip detection ADR, so IBUS guided reentry, and I will show you some cases. Then the last point is the new approach of the old STAR that we call STAR 2.0. Let's start with the hematoma management. So we know that the subintimal space is our friend, is not our enemy, is highly stretchable, is easily dissectable. But the problem that we can have, we will have the hematoma, and the systemic pressure can propagate the hematoma and can compress the distal true lumen. So for this situation, this is a cartoon. We have a systemic pressure, we have the wire in the subintimal space, and the hematoma can compress the distality of the vessel. So we need to think about some tips and tricks to reduce the hematoma propagation. And this is a case you can see is a case of the of antegrade knuckling with you can see this big hematoma, and the distal landing zone is compressed. So after the straw technique, so the technique to reduce the hematoma, aspirating from the stingray and putting a guide extension. The guide extension is another really important technique to reduce the hematoma. you can see that the distant landing zone is much better. So in this situation, we can puncture, we can do ADR device base, in this case with a Stingray. This is a stick and drive with Gaia third. Is a real-time fluoroscopy registration. You can see we are up in the upper side of the Stingray, and then we can confirm that we are in the true lumen distally, and we can do our PCI with these very good final results. So the hematoma decompression is a key point, and then this is why recross can be really useful. This is recross. I think that everybody knows it is the only one dual lumen microcatheter with dual over the wire lumen and the 3 exit port. We can do straw technique, so we can aspirate the hematoma and we can puncture in the same time. So this is something that is not possible with a Stingray. So this is a cartoon. We have the wire in the subintimal space, we have the recross, and we can re-enter. This is a live case that I've done some years ago. You can see here it's not it's quite complex RCA CTO, and then I tried to puncture with the Gaia. I went subintimal, so I had to knuckle. This is the knuckling of antegrade wire, and then is a rolling knuckle. You can see we have a good landing zone for re-entry. That's why I put the recross here. You can see on the video that I advanced the recross over the knuckle wire, and then I aspirate. This is how can we perform the straw technique. So we take a big syringe of 20 cc Luer lock syringe. We put a clammer, so a vacuum on the syringe to aspirate the hematoma. Over the blue lumen, we have the syringe and acupuncture with the Gaia. Proximal, you can see here, this is the Gaia that exit exactly from the white lumen, is quite far from the tip of the recross. And then this was a stick and drive. I confirmed it to be in. Then we did IBUS guided puncture, and this was our IBUS guided evaluation, and this was the final result with the very good opening of both side branch in the RCA. Then let's go to the IBUS for ADR. So which is the big advantage? That we have no need to rely on contralateral injection to direct the wire. And we have an online choice of best area for re-entry. So we can have a pullback, we can choose a site with less calcification, less hematoma, and we can see live the visualization of wire re-entry. So with Stingray and recross, without IBUS, we have to believe in the angiography, in the contralateral injection. Sometimes the landing zone is not good, but with IBUS, we can understand if we are inside the true lumen. So I think in my mind, the best device should be a dual lumen, a recross with IBUS on the tip. But now we don't have on the market at the moment. This is the cartoon for IBUS for ADR. We have the wire in the subintimal space. We put the IBUS. We can see the IBUS in the subintimal space. We can see the true lumen that is collapsed. We puncture from the subintimal space. In this case, we need a very stiff wire like Hornet 14 or Confianza 12 with a wide angle. So the tip should be modified in order to have a wide angle to re-enter in the true lumen, and then we can have a very good success rate. In my experience, my success rate for IBUS guided ADR is more or less 85-90% of cases. This is a case of some years ago. You can see here we have the LED occluded with diffuse disease before and distal to the diagonal. The classical strategy failed, and then I had to knuckle with a field XDA, you can see here, and then try to put the IVUS, and this was the IVUS for re-entry. Proximally, of course, the more you are proximal, the best is the re-enter. So the short is the subintimal tract. So we try to stay more proximal as we can. But in this situation, as you can see, we have a calcification in the vessel, and the wire is outside of the true lumen. So here I was not able to puncture, and then I have to go distally. Distally, this is a real-time IVUS. I was able to puncture with the CP12 exactly inside, and then with the pullback, you can see here again, we have here we are in, and then doing a pullback, the wire go out. So exactly because we were at subintimal proximally. After that, this was the final result after stenting. You can see that all branches are preserved. Then this is a case of last year I've done live in Egypt for MLCTO Middle East. You can see here was a woman with not good retrograde connection, a diffuse disease of the LED. I puncture, I was guided the proximal cap. You can see at 4 o'clock, we have calcification in the middle of the cap, and I tried to puncture, but I was not able to cross intraluminal. So in this point, we were subintimal. We fail parallel wire technique. The classical parallel wire failed. So we put the IVUS in order to re-enter. This is the IVUS guided re-entry, quite proximal. You can see close to the diagonal, and you can see the IVUS in which the hornet is exactly inside the true lumen at 6 to 7 o'clock. And the final result was only with DCB. This case was done without stenting. Then the last point, the new STAR technique is what we call the STAR 2.0. So we know that the original STAR by Colombo was an uncontrolled re-entry with long stenting, with the occlusion of all side branches, and very, very poor good result at follow-up. So we think of something different, and we have two crucial aspects. So the inflow and the outflow. So the key point is the inflow is the CTO body. If we are not able to stent the CTO body, and I call investment, the probability that at the follow-up the vessel will be open is quite low, because inside the CTO body, if you are only ballooning, at the end you will have a collapse of the CTO. Then you have the outflow. So I mean, you need to ensure T3 flow by extensive ballooning. Even if you are subintimal, you will re-enter distally. But in many cases, even if you are not if you don't have a very good re-enter from the subintimal space, if you are going to star even a side branch, you will fenestrate and create a good connection with the distal true lumen. And for this strategy, using the IVUS to guide the intervention is really important to ensure landing zone of maximal intimal compression. I will show you, this is the paper. I will show you a case, really interesting, that this is a case of this kind of diffuse disease of the LED with no good retrograde connection, in which I try all the classical strategy. So puncture with Gaia, then Gladius, unable to wire the true lumen, and then had to I tried the IVUS guided re-entry, but this was one of the case of failure. So this is a bailout technique. So this is a star with the Gladius MG, an knuckle with the Gladius MG. We are distally in the true lumen. You can see the distal LED. Then balloon dilatation, good flow. And then if you have a good flow, you can stent. When you have a good flow, after stenting, the flow will be much better. But if you don't have a good flow, if you have a TIMI0, TIMI1 flow, you cannot stand. You need to invest and to stop the procedure. So the key point is the flow. If you have a good flow, you can stand, and then you can post dilate even distally to the stent. And this was the IVUS that I've done after stenting. This is the angio. This is the angio, the final angio. You can see we have a good flow up to the distal LED. We have all septal distally. We have a dissection in the mid part. And this was the IVUS that I've done at the end. So you can see where we have the IVUS is in the false lumen in the subintimal space, and we have the stent that land in the subintimal space intentionally. And the proximal CTO, the proximal part of the stent, is of course in the intraplaque. So you can see here. This is the follow-up. After 3 months, you can see how good is the vessel. So the vessel increased the size, and we have a beautiful flow, and the patient is perfectly asymptomatic free from angina. So to conclude, in practice, when you have a failure to perform all the conventional CTO technique, and you are performing a bailout star with the polymeric knuckle wire, and you can choose a Gladius or Filler XT, you balloon all the segments, and you have, with injection, TIMI0, one flow, no side branch, you need to stop. So this is an investment. If you have a good flow, TIMI2, TIMI3, and you have a good side branch, then you can perform IVUS guided STAR 2.0. I mean, stenting only the CTO body and then ballooning distal to the stent. To conclude the presentation, the classical antegrade escalation is an old concept. So the modern approach, antegrade approach, include flexibility, fast de-escalation, reducing the use of very stiff wire only to short segment and specific tasks like resistant cap. Understanding the subintimal space is crucial, and if you know the subintimal space, you know how to solve some complex situation, and you know how to use ADR. So the new technique with involving recross and IVUS can mitigate some pitfall of conventional device. And then, last but not least, the new concept of wire-based IVUS-guided ADR STAR 2.0 could bypass conventional limitation. At the end of the story, so the expertise in all components of the hybrid algorithm is a prerequisite for high success rate and low complication in CTO PCI. Thank you very much.
Thank you very much, Dr. Garbo. This was really an excellent update on the antegrade techniques. Any comments from the audience, from the panel?
I have one question. When you do the IVUS guided or ADR, I saw that in your case you prefer the volcano IVUS, right? But because I think that the volcano IVUS you cannot move back and forth easily, so it's difficult to do the tip detection ADR, because the tip detection ADR you have to move the IVUS catheter back and forth to see the shaft and the direction of the tip. But with the volcano IVUS, I think it's difficult. The second operator cannot assist you.
Yeah. Okay. So thank you for the question. I think this is a great question because we don't have in Italy, in Europe, the ante-hole IVUS that's a Japanese operator have in Japan. So we have some mechanical IVUS. I think that in my experience, I like more Philips Volcano IVUS in that situation. We need to work at the same time. We need to work with two operators. So mainly, as you said, so the second operator, I can move my IVUS that is a little bit bulkier than the ante-hole IVUS. But if you're able to enter, we know that subintimal space is highly stretchable. So we can enter the subintimal space with a eagle eye IVUS, and then we can check very easily the point in which we have the hematoma and the true lumen. At this point, we can try to stay, not to move too much back and forth, but we stay in a position and we move, we look with angio, the position of our Hornet 14 guide wire that is opposite to the wire in which we have the IVUS that is in subintimal space. And then we look at the IVUS and we try to check IVUS and angio together. And once we are in the true lumen, we can advance the microcatheter and then we can switch with a soft wire. So this is normally the technique. But we can use also the mechanical, yeah.
Thank you very much.
Just a comment, in Europe we have assist system and a Vigo from Boston Scientific which we can use for tip detection. Moreover, that both systems are high definition with 1460 megahertz transducer, so it is a question of availability in the cath lab.
Yeah, so if I can say something, the problem that because I'm using also a lot of Boston IVUS, and I think that when you increase too much the megahertz, you go up to 40, 60 megahertz, you have beautiful imaging. Okay, I agree. But then sometimes you are not able to discriminate very well the difference between the blood and the plaque. So this is something that you need to think about. So with the volcano, with the eagle eye, you can clearly see that the black part is the blood, and then you can see the plaque, the true lumen. So we have much more contrast. When you have a beautiful imaging, and in many situations I've seen with the Boston that you can see very well the plaque, but then the blood seems similar to the plaque. So you have two different kind of gray, and sometimes it's not so easy to make the difference between the two different space.
And Dr. Gabro, with these new advanced achievements in the antegrade technique, what is the, let's say, the success rate of the antegrade?
You are talking with IVUS guided or
no,
or,
as a whole. I mean, everything that you've discussed, antegrade, the modern antegrade approach to CTOs.
This is a really important. Yeah, this is a. So in my experience now, my success rate is last year was 98% of success rate in CTO, and considering really a big number like more than 350 overall. But then with the modern approach of antegrade, we reduce a lot the complex retrograde. I mean, in the past we did. We know that we can do complex epicardial connection, retrograde approach. So technically we are able to do, but we need to think to balance safety and efficacy. So from this point, I think that the antegrade approach will be, with new device, with new guide wire, more and more useful to reduce the risk of complication, and with very good results. So I think that now we can consider that 80% of cases we can solve antegrade, and we can go with retrograde approach in no more than 20% of really complex cases.
So Roberto, this is a nice presentation. Thank you. This is Shevket talking.
Hi, Shevket.
Hi.
Hi.
So
good to see you.
Yeah, good to see you too. So my question is, everyone is going to an integrated approach, and I think expert operators are trying and using different integrated techniques, and you are now going to a different direction from what I am seeing here. So this is not a tip detection IDR. This is something you are doing. So how do you see these techniques to be reproducible in terms of teaching? You know, so we are old school. We know what to do with retrograde, and if you compare it with retrograde teaching, how would it be the learning curve? What's your assumption regarding the learning curve and the reproducibility of the techniques with ADR techniques, with IVUS-guided ADR techniques that we have now?
Yeah. So very good, Shefkat. I think that the key point, we need to talk about modern approach to PCI. And I think that the key point here is that operator need to understand very well the imaging. So if you have a good understanding of IVUS, you can use, and there's a learning curve for antegrade, but even for retrograde, because you know that sometimes we need to face complex reverse card in which we are not able to make the connection. And I'm going to teach to the young generation that if you put an IVUS inside your vessel, inside your reverse card failure, you can understand the relationship between antegrade wire, retrograde wire. You can understand if you are intraplaque with antegrade wire and you need to increase the balloon, or if you are in the type 4 situation. So retrograde intraplaque and antegrade subintimal. In that scenario, we know, because we are expert, that we will never be able to make the connection increasing the balloon size. So I think that to answer to your question, there's a learning curve to understand the imaging. But if the operator will go more and more with IVUS, will be much easier and effective in the future to obtain good success rate. I think that this is something which we need to improve the education, and for that, the concept of tip detection ADR from Japanese is really important, because they have there's a new era for IVUS in reentry, and this is important because people want to understand, want to try to imagine in his mind, how can I able to do tip detection ADR. So I think that sometimes Japanese explanation is too complex, and I think that IVUS is not so complex. So we need to try to be to explain and to make a complex thing more easy. And I think that we can do that, but we need experience. We need to educate operator and doing IVUS.
Thank you, Dr. Garbo. Hope you see you soon in Bulgaria. Wife.
Thank you, Valerie. Thank you. It was a great pleasure being here online with you, and I wish you a great meeting. Thank you so much.
Thanks, Robert. Bye. So we're going with the program. Shefkat, Dr. Gorgu, please. Indications for CTO revascularization in 2025.
That's not mine. Let me choose by myself if it's possible. Okay. Let me see. Okay. So, yeah. So, before I begin my speech, I would like to thank Professor Vasilev and Gelev for this nice invitation, and I am also thanking the Bulgarian Interventional Congress Organizing Committee for having me in front of such a distinguished audience. So, so this is the latest expert consensus I've gotten my hands on, and I will try make my speech in alignment with this report. The treatment of CTOs is clinically and technically challenging and requires a close collaboration between the referring physicians and specialized centers. This is the first line of this report. But unfortunately, in this case, there was no such collaboration. And this was an only patient they offered to me for a proctoring in a hospital in India. And the patient was already on the table. So I did my best not to take this patient. I argued with the responsible physician, and the team get upset. Okay, there is strongest indication clinically, according to this report, and according to some kind of randomized trials in terms of symptoms, of course. But according to the European guidelines, there is this indication this patient has class 3 angina. But according to the American guidelines, this patient, the angio that had been done 1 year ago showed no distal target. I couldn't see any distal target, and the patient was on the table. Then they said to me, let's do an angio first, okay? And then they said, dual angio first. I said, no, we should gonna do a triple angio, triple injection. And that's how we proceed on this case here. So I asked them whether they have discussed the risks involved regarding this procedure, especially in this patient, that this patient might die. So a creatinine level is around 3. And then they said, no. I flipped again. And then they went out and talked with the relatives. They agreed to proceed. So actually, this should have been done before, maybe 1 week ago. But this is what we have gotten here, and you can see the triple injection that they have done. I was outside and waiting to see no target and cancel the procedure. And here we are again. And we calculated the mortality rate is here, in this case around 1%, and we have a lower technical success rate, more than 10% perf rate, and a dry tamponade, which can cause, of course, very serious consequences here. And then this JCTO score is 4, Castle score 5, progress CTO 3, progress CTO complication score is 6 here. And then this was another problem, was that this was going to be an ad hoc CTO PCI, and from the consensus report we know that this is discouraged. Okay, we do not do ad hoc CTOs. And additionally, this is an LAD and a post-CABG CTO, and I asked the responsible physician whether they would reconsider a heart team endorsement. I asked. The responsible physician said no. Then I said, what the hell, let's go and then see what we can do. So here, the problem here is we need a distal target vessel. First, we have to obtain a distal target vessel. We don't know where to go. This is an ambiguous cap. We don't know antegradely where to go. We don't know retrogradely where to go. And the distal target vessel quality is not good. And the MACE rates are higher, the technical success rates are low, and the option we can treat this is, for me, only retrograde. I don't see any antegrade here, and it's very messy here. So and then I talk with the physician again. Okay, this is the circumstance here, and if we even manage to open this artery, this is the distal vessel quality is bad. We might end up with some kind of no reflow, and is this really worth it doing this case? And he said, no, I want to do it, because we have also calcification, as you can see, and we don't know which collaterals are filling the distal LAD. And symptom improvement is the primary indication for CTO PCI with the strongest evidence to date. Okay, there is class 3 angina, no problem with the indication. If this patient had no symptoms, with an ejection fraction 35% and silent ischemia with viable myocardium, is it warranted for an intervention? The MRI showed more than 20% viable myocardium. The consensus document suggests intervention in selected cases, which means young patients and proximal LAD patients, or patient does not fit into this criteria if he had no symptoms, but he is symptomatic. So this is what we have done. I said, okay, let's probe for an saphenous graft, And it was not that difficult to probe into the saphenous graft here. We went in with an ultimate bros. And then here we did a tip injection. And then it was a retroflex connection from the distal, from the mid-LAD towards the distal cap here. So this was the situation. We checked from different positions to understand how to go there and how to overcome this retroflex distal cap engagement here. We tried for 1 hour, used everything, supercross, dual lumen microcatheter, and 2.6 coiled microcatheters. And then we went in several times. It took us 1 hour with NREACH 0.3 gram, and then with filter XDR. But even this 1.7 microcatheter always prolapsed into the LAD here. So, so as a last resort, what we have done is we put a balloon distal at the part, and then to prevent this prolapsing, distal balloon inflation, and this was an NREACH 6 gram with an H curve. It's a strong wire. And we blocked the distal vessel. And then what we have done, we were able to somehow engage into the vessel itself. And you can see we brought the microcatheter upwards. The visibility is not that good. But here you can see, and then what we have done, a Carlino, yes, and the Carlino solved the ambiguity, creating a perf. That was what I was expecting. I have told everything to the physician, this can happen, and step by step, we every time experience this kind of thing here. But now I have at least a target to go, and trying to knuckle upwards, I have an ambiguous course. I don't know where to go, so I have to knuckle. Filter XT didn't work, Gladius EX didn't work, MG didn't work even, and I was able to knuckle with an NREACH 6 gram P here, and then the body went somewhere, and then I was able to advance the microcatheter, and then here giving contrast, trying to understand the course of the artery here. Come on, yeah. So, and then we have a perf there, but fortunately it's going to be retrograde. And here you can see still the ambiguity exists. Let me show, I should go a little bit faster, but this one here should be also working. Okay, so I'm trying to understand where to go antegrately. And now I have my turnpike spiral there, and my knuckled wire is up somewhere, and I'm trying to puncture towards that knuckled wire there. This was a Pilot 150, and I was very lucky that I go there. First I go into the septal, and then I went into the distal vessel, finally in the distal LAD, as you can see. So then comes another problem here. So if you do a case outside, if you do proctoring, then every cath lab has their own doing of ways of doing on it. Okay, this is a problem. So we had a perf, and then we had hypotension. The patient was sweating. I flipped again, and then we find out that the patient was not catheterized. The bladder was not catheterized. If you do a CTO, always, one of the first preparation is you should do it. Okay, and then I figured it out. It was a Wasserwagel reaction because of this retention of urine in the bladder. And we were already down with our microcatheter, and we have to cannulate the patient, and then we went on. And this is how it's going to be. We stand it. There was no branch loss, but as I have assumed, we have a TIMI2 flow with this distal vessel, but we were lucky. The patient was discharged 2 days later. This was the most important thing for me. We didn't kill the patient. So, and the CX was managed again. We had a DK crash or something, mini crash or something there. So the indications are very, very important here. And if we have in patients, if we have symptoms, it's okay. But the patients that are under surveillance are the patients who have no symptoms, but the goal is to improve the survival. Do we have evidence to improve the survival? Do we have evidence to improve the left ventricular function? Is this an indication to improve left ventricular function to do a CTO PCI? According to current consensus, unfortunately, no. So these are the studies, the randomized studies, and the randomized studies doesn't show any mortality benefit. So this is a comparative analysis between the registries and the randomized trials, but we have problems with the randomized trials, actually. They are not representative of the real world patients. Okay, we have 6 randomized trials investigating optimal medical therapy versus PCI. Only 3 of them were multicenter, and only 1 was powered to assess MACE, but this one had a 20% crossover rate, fewer comorbidities and less risk profile compared to registries, less complex CTOs than the world registries. So decision making in current medical practice should be based on evidence, of course, but with this randomized controlled trials, it's not possible, and the registry is telling another story here. So this is a 41 years old patient, and he was undergone 2 times unsuccessful RCA CTO intervention. The last attempt was in 2018. And 3 months ago, our intention was to try it again, but he passed away due to sudden cardiac death 3 days before the procedure. I have experienced and listened to stories like this one, at least concerning 5 patients. However anecdotal it is the real life data. All the real world data validate actually my experience, but it is no scientific evidence. And all the real world data is compatible with the meta-analysis and observational studies, whereas the randomized trials tells a different story. So we know what happens when a patient has a CTO and comes with an ST myocardial infarction of the donor artery. We know the prognosis is dismal. So this is not a good thing. And then this is another meta-analysis, a very large meta-analysis, 33 observational studies, successful versus failed CTO PCI. We know that successful CTO PCI has a better MACE rate, has a better cardiovascular death rate, has a better mortality rate. We know that already. So, and another thing is, if we compare it with optimal medical therapy, it's also beneficial. And in terms of cardiovascular death and in terms of mortality, we are still with the registries on the better side with doing neovascularization rather than doing optimal medical therapy. But this is a meta-analysis. And again, MACE are also better in successful and unsuccessful CTO if you compare it, and if you compare it optimal medical therapy with PCI, CTO PCI, and the MI rates are also better here in this meta-analysis. So this is another registry here. In this registry, revascularization rates at 10 years, acute coronary syndrome hospitalization rates, and all-cause mortality rates were better and statistically significantly better than optimal medical therapy. This is another evidence, if you will take it. And the problem with the randomized trials is we have only, I think it was a decision CTO trial for following up to 3 years, and the other randomized trials, the follow-up is about 1 year with less risk profile patients. And we have seen in this registry that the actual benefit comes after 3 years. So after 3 years, between 3 years and 10 years, we have a benefit in revascularization these patients, and we improve survival in these patients, and this is in alignment with our daily practice experience, but no randomized trial. Okay, so this was another case. It was a CTO Essentials case. So this patient was asymptomatic, and according to the consensus document, this patient has no indication maybe for intervention. So it's an RCA CTO, and you have an LAD 70-80% asymptomatic patient, 62 years old. But we did it. So we did it without proof, but we did it. So let's see what we have done. So we had the LAD was diseased. So we tried to go integrate first puncturing with 12 gram, this enriched wire here. They escalated to 3 gram. And then we went into one of this PL here. We thought this was a PL, but it was not a PL. The CT guy from the audience said to us that this is a side branch. Actually, this is not the PL. We don't have a PL. This is only a very small RCA that we should go after. So, and then what we have done, dual lumen in and try to puncture towards the PD. And here is what's going to happen. We are in the subintimal space and with enlarging hematoma. The only option here is going retro. This was an N-reach 0.3 gram C, and this was a beautiful for me performance with this wire here. I want you also see this. It's not going to be that long here, but here we were managed to go fall into the retrograde, and then this distal cap puncture with again polymer jacketed wire, and we are in the aorta, and then we go into the guiding catheter. What we are doing is then we are doing tip-in here, and here this is along 2.6. It gives me a good support, and I'm very happy with this micro catheter. So far I haven't failed any after tip-in going down with this micro catheter. Sometimes I have to feed it from the back, sometimes not, and this is how it looks at the end. And we had a perf, and actually the CT guy was right. We have a perf there, and with outside the waiting operators, we decided not to do anything here to this perf, and we finished the procedure. So this is how it looks for me, actually. Performing a CTO procedure is for me like a marriage. We don't have evidence, but we are still doing it. So thank you very much for your attention.
Thank you, Şevket. It was impressive as always. So now is the time for questions, comments.
So, Şevket, I have a question. So you have shown us all cases done retrogradely. And in the last talk from Roberto Gabo, it was almost everything done antegradely. So you don't need antegrade CTO PCI, or where is the advantage of antegrade CTO PCI? What do you think in complex cases?
So, okay, this is a good question. So actually, I have seen your study with Recross, and your success rate was about 96%. We have new wires, new microcatheters, and I don't do intentionally retrograde, so I fail antegradely. So sometimes it depends on persistence, and I think the operators are persisting. If you are in a beginner phase, then you persist longer, okay? And if you are some kind of expert, you have a low threshold for going retrograde. And if you are a super expert, like Muhammad, you don't need retro anymore. So this is my answer.
I don't need retro anymore?
Yeah.
I don't need antegrade anymore.
You don't need antegrade anymore?
No, I mean, of course, retrograde makes our life much easier because you can solve almost every case once you go retrograde. Yeah. But what about antegradely? So how long time do you spend antegradely before you change to retrograde, as you are also an expert in retrograde CTO PCI?
So the thing is, I do actually almost that I can. We are working with Dimitar and Nicola for 2 years, and they know we do everything. We do first, we are actually doing the old school, okay? So Roberto is showing us a new concept that the CTO award is going through ADR with IVUS, something like that. But we are still doing the old school. We begin, if we have a channel, we begin with a polymer jacketed wire, and then we do wire escalation, and then we do parallel wiring, and then for the last time, and the parallel wiring is going to be exceptionally always with a dual lumen microcatheter. And if we fail, and if we see that some hematoma is accumulating in the distal vessel, and that's time for us not to proceed any more further, because if you insist and trying to do more and more with different wires and trying to puncture somewhere and going down, and then you increase the hematoma, and this is not what we want. That's the reason why we switch retrograde, but we do everything we do. And for my last attempt, I think regarding the nomenclature, it might be not in the armamentarium of parallel wiring. You can say to it an ADR, you can say to it it's not in parallel wiring, because according to the definition, you should use a heavier wire than the first wire. But sometimes, as a last resort, I'll always use polymer jacketed wires, Gladius for example, and it creates miracles. After failing with the parallel wiring, I try to go with one of those fenestrations, to sneak one of those fenestrations that a high tip load wire has created, okay? And if Gladius fails, and if I have accumulating hematoma in the distal vessel, that's now in a failure mode, so we have to switch.
I would like to ask George to give his answer from the...
Yeah, I will give the answer there. Simply, we'll make a very short comment, because there was a lot of discussion about antegrade, and everything has to do with risk. That's a key point. But the last case was the case that it should not be done antegrade, the one that you presented. Because if you're going directly retrograde, you have solved it in 1/4 of the time, with 1/4 of the materials, with 1/4 of radiation and contrast. Do you agree?
Yeah.
The collateral was so big, it was a highway, and there was absolutely, for an experienced operator, as to why he should insist on complex antegrade versus a simple retrograde. So all of these things in the CTO business is relevant or irrelevant.
Yeah, but then...
But I learned something today about marriage, although my wife is here.
Okay.
So anyway, contemporary, first of all, thank you very much, Dr. Yelev, Dr. Vasiliev. It's a great pleasure to be back in Bulgaria, as always. We have a history here of, I don't know, Dr. Yelev, from 2007, 2008. From, yeah, 2008, so it makes it 17 years. Maybe I've categorized more CTOs in Bulgaria than anywhere else, and certainly more than Greece. So, this talk, is that working? Is going to focus not on technical aspects, because quite a lot of the decisions, I will present some cases, but it's not going to be the main point of it. What is the important thing, because you heard a lot of things about the antegrade, retrograde, ADR, and ADR is the most evolving thing. And you have to be a believer, and if I have to make a comment from what Dr. Garbo presented, although I didn't take the microphone, he showed that there was a dramatic reduction of the ADR of 60% to 10% in the American data. What does that show? Is that when you violate the rules of the anatomy, you have these kind of things. Because when the ADR was invented at the beginning with the Stingray, I will not mention the company, then it was considered from the beginning for all comers. And that's not true. And that's exactly the answer to all of the talking that we have now. Because one thing that it is the baseline thing, anatomy dictates strategy. And then you put the risk, and then you put the operator skill and everything else. So this is a history of the CTO PCI. I'm not going to insist on that, but I'm just going to show you that the first retrograde was done back in 1990 by SVGs. And if you see the first retrograde via septal collaterals was done 9 years later. Okay, so it's not a very new story, and you saw a retrograde via septal collateral present in a very complex case that had to balance with indication. But the real modern era of the retrograde CTO PCI starts in 2005 with the inventory of the CAR technique, control retrograde tracking, or if we want to speak into the real terms of today, retrograde RDR, retrograde dissection reentry, that is what's CART. Okay, it might have the name of the original Cato presentation, but at the bottom line, it is what it is. And you see here that we're talking about a continuum. This is a slide that is 20 years old, about the antegrade, retrograde, and dissection reentry, and we're still there. There is nothing changed since that time. The only thing that changed is that we do, at the time we were saying try integrate, put the patient out. If you fail, you bring him back for a retrograde and this and that. And today you saw kind of cases what have been presented where the paradigm has shifted. But that's all. Okay, antegrade, retrograde, and dissection reentry. And this is one of the very first slides. This is publication of done by Cato in 2005, I think. And the concept of the retrograde, because I will present you a little bit of the history also. And we're talking about 2005 of these CTOs, which is 1 mile long. Okay, it's not a type A CTO that you do retrograde. And what he did at that time, we're talking about the pre-microcatheter era. Pre-microcatheter era means that there was no concept of sliding something without the balloon. We have only over-the-wire balloons at that time. And what that meant, when you put the device down and it has balloon capacity, then you dilate. You put it anyway down there in the retrograde and you dilate. And that was the main thing. As you can see, there is antegrade wire thing. You go over there with a retrograde over the wire balloon and you dilate. And this creates a space for antegrade probing. And that was the result. And that's just what we call control. The CAR technique has been described by Cato, that revolutionized the field. And then in 2009, we had the advent of the microcatheters. Corsair came, and you see what happened with a period of 16 years. This is not the purpose. But what it led, instead of retrograde dilatation, because you have the capacity of the device that doesn't have a balloon at the tip, we said, okay, it's easier to push, and you see how all these modern microcats are performing, but there is a balloon there, and so we inflate the other way around. Instead of retrograde, we inflate antegrade. And then we created a reverse card, and that's where it happened. And we're going to talk about now the evolution of it. And the conventional reverse card Cato presented was based on the fact that the balloon has to be 1-to-1 with the vessel size, okay? I was guided on all these kind of Japanese things that halfway down the river we were sleeping after a few years of the excitement. And this is called the conventional. And then you have the directed, which is the modern day, that you have to bring the two wires close to each other as much as possible. And then a balloon of 2.0 is enough, and then the trauma is less. And what is in the case is that this whole process is happening within the CTO segment, and that's important. So you don't injure the proximal, you don't injure the distal vessel beds. And then you have the extended, for whatever the reason is, as presented in cases now. This is the most traumatic of all the retrogrades, that essentially you have to extend the retrograde connection outside of the CTO segment. And all of these, they have issues because they have related to complications, and I'm going to present this data to you. So if we're talking about today, we're talking about two techniques, okay, the antegrade wire escalation and antegrade dissection reexis, so antegrade and retrograde A and R, and both of them, they have the simple thing, whether it's the wire escalation or it's dissection reentry. That's all the business, and that's the terminology around it. And the same thing you see here in a later presentation with the modification of the hybrid algorithm. I'm going to go to that. So there are all of these things that you have to evaluate when you're doing a CTO. Okay, you have to see the distal cap, you have to see the proximal cap, if it's in standard stenosis, the vessel course, the length, the calcification, the redo, and the collaterals. And that's what I was referring. Do you have great collaterals? It might be safer to do a retrograde, but I'm going to come to that. So we're talking about the JCTO score. That was a score that was created for undergrad CTO PCI, and this has been modified by the Japanese for the distal era, and you have the retrograde JR-CTO, okay, the retrograde CTO, and essentially what is remaining there out of the, and that's what I'm telling you, the calcification remains as compared to the JCTO score and the tortuosity. All the rest is gone, even the length, because the length of the occlusion in the CTO is irrelevant. But you have the collaterals, whether they are continuous and whether they are non-septals. So if you are talking about that and you have to investigate retrograde shocks in CTO PCI, you have to take into account these kind of things. What is the most important thing, and is always surprising to me, and it is still remain data, and we have to believe the data, that the success rate of the retrograde is inferior to the antegrade. And these data were existing since long time. You see a success rate of 78%, and people are now declaring, and they are true data from experts, 98% success rate. But we're not comparing oranges with apples, because the retrogrades, and Dr. Garbo mentioned it, are applied most of the time in far more complex CTO than the antegrade approach. And the dilemma about antegrade and retrograde is fake, in my view. Because if you put an operator like the operators that are sitting on this table and you tell them take JCTO 5 cases, the esteemed antegrade success rate of 85% is not going to be so, I suspect. Okay. Then you have to do more different things. But if you do JCTO score 3, yes. Okay? What is happening now? And you see here, which are the techniques that are, and the other thing, sorry, and the other thing is that for the first time, because both Shefket and Dr. Ayubi are here in the younger generation, but in the initial, back in 2007, we're saying that the CTOs, they have the same complication rates as non-occlusive disease, and that was proven wrong, because the 3.5% or a 5.8% complication rate is not existing in the non-occlusive CTO PCI. So we start realizing these kind of things, that it's more complex and is more costly, it's more complication. And what you see here is that you see here the success, and you can appreciate that still the mainstream techniques that are coming haven't been talked, but the retrograde wire crossing true to true is 1/3, and CART is around another 1/3. And you see that the guiding catheter extension, and I'm going to show you the technique, is around 20% of the cases. And you have all these very traumatic, the extended reverse CART and other procedures. But that's a little bit about what we're working today. True to true, in the retrograde is 30% of the cases, okay? Don't forget that. It's a rather simple procedure. Here also you see what kind of collaterals we're using, and most of them, as you can appreciate, they're septal collaterals in 72% of the cases, and the rest, around 20%, and 1/3 of the cases, you have to use epicardial collaterals, just to go into some details. I'm not going to insist on the complications because I'm pretty sure Dr. Ayud will address that, but you have to see that you have a very big amount, around 60% of the complications in the retrograde, while we're talking are channel perforations. You have donor vessel complications, you have peri-procedural MI, and you have vascular access complication, but I will skip that because I'm going to tell you the following, is that the retrograde techniques, they have been associated with the higher rates of complications. This is European data back in 2018 when we analyzed. Coming second, the ADR, and the antegrade wire escalation is the best. So ADR that we're talking so much about, it's not so innocent. And you can appreciate also that the retrograde technique, based on these things, came with an increased risk of 3% in complication, not 3%, threefold compared to the rest of the techniques. Okay, and you can appreciate here others on the complication rate. And you see here some American data now. What they are presenting is that you see here they took only the complication rate, and you see that the more the complex retrograde, like the extended reverse CART, the higher the percent of complications, which is reaching around 15%. And I am insisting a lot of the complications because all of the questions that they arose before, you do retrograde, you do retrograde, and you do this and you do that, everything has to do with the fact that these are more risky procedures, and this is stable coronary artery disease. So you have to find a balance. If they didn't have any risk, then there is no need not to. Okay, and what we know about that, and as you can appreciate here, this is a progress CTO score, and the presence of a retrograde technique increases 2 points. Okay, all right, but Again, it was part of the talk about the indications. When I'm giving a talk about indication or the techniques, anatomy dictates the strategy. And that's something that it is, for me at least, the major denominator in the decision making. Okay, and it comes to the other point now. Again, from data back in 2015, European data, the more the experience the operator, the higher the success rate and the lower the complication rates. The more you do, the better you get. Not only the efficacy, but also on the safety. Okay, and not only that, I didn't include in this slide, but you have sustained high success rates in the most complex of the CTOs. And that's a key issue. The very experienced operator will have a sustained very high success rate in JCTO score 5, while you see less experienced CTO operators, they lose success rate into the very long complex cases. So, these are all the steps. I'm not going to insist, I have 6 minutes, but essentially what you have to do is, when you have first of all to decide for retrograde, select collateral, you have to reach the collateral, you have to cross the collateral, you have to cross it with a guide wire, you have to push a microcatheter through this, and then you're working with a CTO and externalization, all this kind of stuff. I'm going to show you some examples of all of these things. So I want that you keep, because this is not a super, the meeting is to present you some concise data of what you might be able to have. And what you see here, this is a case that comes with this post-CABG patient and this RCA CTO. This is a case copy of Shefket. I wouldn't try this case under grade personally. When I have this collateral, there is no need, but I did, and led exactly to the same thing as he did. And of course, it didn't lead anywhere because the expected success rate of undergrade is 10%, or at least in my hands. And there is very good collateral that was very easily crossed. And what happened here, you see this wire, okay? And there is you can appreciate the wire course, lesion tortuosity. That was not possible to be evaluated in advance. And the retrograde wire crossed to true, okay? All right, and then this is the result. And you see the entire true, when you finish the procedure, it doesn't matter the technique, and retrogrades have that. They showed you your struggles. And the struggle in this case was what? This extensive calcification that you can see here. And that's why this undergrade fails. First of all, you finish the procedure and you understand the problems when you finish them. All the problems of what happened to you during the procedure, it comes a full appreciation after success. Okay? And this is a classical example. You see another case now, that's in Geneva 15 years ago, an 89-year-old lady. The reason that I'm showing that is that at that time we were crossing these collaterals. You can appreciate, I didn't insist, but what you can appreciate there is that tip injection, you see the complexity, by having, and this is a message that you have to have, by having a retrograde wire doesn't mean that it will cross through to true. It can go as wrong as an undergrade wire, okay? And you can clearly see it here. Doesn't mean that the distal cap is any different than the proximal cap. We know that today. And your retrograde wire can go as wrong as the antegrade, as it happened in this case. But at least you have a target to see. And what happened here, as you can see, there was an antegrade probing that comes. Antegrade wire is coming. You can see it here. And then there it is. The retrograde wire is completely off. You see the antegrade office, the wires are coming together closely. And that's what we call today contemporary reverse card. 2O balloon dilatation, okay? And then the retrograde wire crosses, you can appreciate it here, enters the guiding catheter, and you finish this procedure. That's, the previous one was true to true retrograde crossing, and this is the conventional card, okay? You put the wires together, and then you're crossing. And this is the result in this lady, okay? I'm going to show you another case. The left treatment in this lady was a nightmare, far worse than the retrograde. Okay, I don't know why I'm stuck here. Can you play that by somehow?
Можете ли да Пуснете филмчето над място.
Or exit the presentation and go again.
Не става.
The concept here, I was going to present you the evolution of that. It's a heavy presentation.
Ако искате, излезте от presentation мода и го пуснете като...
Go down. Yeah, this is a slide. Just try this one. Yeah. All right. This is a young man, 40 years old, cabbage. He had an occluded LAD. He was tried 3 times. And the reason I'm going to show to you, again in my hands, quick antegrade, that's what we're going, double parallel wire, as you can see here, still failing. And then he had this vein graft into the right ventricular branch. You see the retrograde, tortuous collateral. Today is not a problem, this collateral can be crossed. The corsair failed in this case, but a fine cross crossed. But the key thing here is that you see where we're standing, and the failure 3 times this guy came with a lima failed. You understand the value? And that's what I'm telling you. You see guiding catheter extension, you see the balloon dilatation, and essentially you use the guiding catheter extension in order to facilitate the reverse cart. Okay, that was the evolution. Through wire crossing, reverse cart, guiding catheter extension, and you can see the example here, okay, that you have it here, the guiding catheter, and you target this, that allows you to facilitate that. That's the evolution of that, and I presented to you. And this case finally finished successfully. I don't know, I'm facing some issues here. This is another case. I just want to present you a little bit more complex. I will take 5 minutes extra. And you see a right coronary. This was done in South Africa, in Bloemfontein, years ago, but it's a nice procedure explaining how complex the things can be. This, again, a post-cabbage patient, and I like to present post-cabbage patients because they represent the very essential of what we are doing. The antegrade wire didn't go anywhere, as you can appreciate there. So there is a retrograde wire crossing. We have some issues with the presentation. Maybe it's too big for this computer. But you see a first wire crossing, and that happens to the what happened in this case, as you can appreciate, we go there because when you do post-bypass patients, the vein graft is always an issue. And you can clearly see this anatomy here, that there is a vein graft, there is an anastomosis in the mid of the PDA. The straightforward direction is the PDA, and then you see a tortuous vessel, which is essentially protracted by the anastomosis PDA. And what's happened here is the anatomy. You see in red the vein graft, you see the complexity that it comes, and the CTO exactly the distal cup. So what happened there, you see that the retrograde wire, it doesn't go. And it goes, all the wire, this wire goes always to the PLA, as you can appreciate there. So the only way that you can do is the second retrograde axis. You can appreciate it here. We went from a more proximal collateral. So that's what I'm telling you. The reason that I'm telling you all these things is that there is no end in the complexity and improvisation into the retrograde CTO PCI. Double retrograde from the PLA to align well to the distal cup. And what happened here, we're able to do reverse cart, as you can appreciate there. Okay, first wire is externalized, the lesion is predilated with a long balloon, and there is a guiding catheter extension. I hope you can see it over there, very close to the distal cup. You see the marker of the guiding catheter extension, okay? And essentially, because all of these things are coming together, in the same patient you do reverse cart, you do that, and then you go guiding catheter extension from another route. And you can appreciate that the retrograde wire of the PDA now is able to enter the guiding catheter extension that reaches that, cross essentially the occlusion. And finally, it was externalized. And this is the final result after making sure that one of the retrograde catheters is moved before standing. I'm not going to go into these things because it became too long. IVUS has a lot of applications into the retrograde. The only thing I'm going to show you, and this is going to be my last case, is that these procedures, as I told you, they don't have any end in the complexity. This was a case that happened in Athens. The patient had an inferior MI. They failed in the primary PCI. They kept him for 6 months. He got a lot of angina. And what happened here is exactly these kind of vessels that you can see, an extremely tortuous vessel that you go by knuckling as much antegrade as you can, and then you cross retrograde, okay? And I'm finishing. I'm sorry that it took so much time. The reason that I'm showing you is this one, that you're knuckling antegrade and you are knuckling retrograde, and there is guiding catheter extension that fails and all this kind of stuff, but see the tortuosity of this vessel. So by dilating and pulling and by pushing, so the retrograde has a lot of options, and finally it was externalized, and we reached to this point. I will stop my presentation here. I hope I addressed a little bit the issues. I just wanted to give you the sense of all of the discussion. That's my final statement about antegrade, retrograde, and all this kinds of stuff. At least to my personal opinion, is completely artificial. It has to do with the anatomy, and there are cases that they cannot be done antegrade, and there are cases that they can be done antegrade, but it's better not to be, and there are cases the other way around. Okay, thank you.
So I propose just to save some time to ask Dr. Ayub to give his talk, and then to make a discussion regarding the topics, because probably after the complications presentation will be also a lot of discussion, let's say so.
Thank you so much. Thank you for your invitation, having me with you. This time it's a beautiful city. I'm very happy to be for my first time in Bulgaria. And thanks to Dr. Sianos for the great presentation as well. It's always impressive to see how, let me say, older operators were working years ago. So now we have more luxury because we have better material, of course, and they did also a great job like 10, 15 years ago. So it's always impressive. So we will talk about complications in CTO PCI. As you see here, it's a big range of complications what you can make. You can have all kind of complications. You can have dissections, vessel occlusions, myocardial infarctions, perforations. You can have troubles with your microcatheters. So if you take a look here, you see mostly common perforations are myocardial infarctions, perforations, and of course renal issues. As has been mentioned in the previous presentations, if you go retrograde or if you do ADR, as you see here, you have higher rate of complications, you have higher rate of perforations. In my opinion, it's related to the complexity of the procedures. I don't think that retrograde CTO PCI is more risky than antegrade CTO PCI, depends on the case. But of course, if you have to go retrograde, that means cases are always more complex, have a higher GCTO score. Mortality you get due to cardiogenic shock or perforation, cardiac tamponade, so we should avoid that. If you have LIS1 perforations, that means blood is just staining in the vessel wall. It has no connection to the cavity of the pericardium. You can treat it conservatively. If you have LIS2 or LIS3 perforations, you can try long balloon occlusions. In more than 30% of the cases, long balloon occlusion would also stop the bleeding, especially in LIS2. Otherwise, you should go for safety and put cover stents. So, as you see here, predictors for complications are, of course, older patients. They have more fragile vessels, so we should be careful in plaque modification and sizing of stents, the balloons. Retrograde approach we mentioned already, and of course more complex procedures and higher GCTO score. Post-CABG patients, they have also a higher perforation rate. If you see here, 2 times higher than non-post-CABG patients. Of also, technical and procedural success is lower than non-post-CABG patients. It's very helpful if you are experienced operators, because that means you have good volume and you have good training in retrograde CTO-PCI, for example, or IVOS controlled re-entry. That means your success rate would increase and your complication rate would also decrease. If I talk about myself, of course, I have a good number of complications, but I do more than 500 CTO-PCIs per year. So here we see main vessel perforations we should avoid in post-CABG patients. Why? Because they have no pericardium after the CABG. So once you get perforation, you will get only a hematoma somewhere, and you will not be able to drain the blood. So that would cause more problem for the patient. So especially in this kind of patients, we should avoid perforations. Once we have a perforation, we can go for immediately balloon occlusion, stop the bleeding. You take a second guide, like ping pong technique, and go with a second wire beside the balloon, which is inflated. So you deflate for a couple of seconds, you go with the wire, and you can work over the second guide. And that way, you will avoid having cardiac tamponade, and you should have enough cover stents in your cath lab. So not only one, I prefer, of course, to have more, because you have sometimes bleedings. You need 1, 2, 3 cover stents to stop. Collateral perforations is also an issue, especially if you walk retrograde. To avoid that, we have always to understand the collaterals, the collateral road. So we have always projections we do for septal collaterals, for example, or for epicardial collaterals, because we want to understand exactly the road of the collateral before we go with our wires. In septal collaterals, it's not that issue. Sometimes you can do just surfing, but especially for epicardial collateral, it's important. And you should use low traumatic wires for wiring of collaterals, like SU03 or Cyan Black. I use also Cyan Black for epicardial collaterals, but only as an escalation, so we should avoid that. SU03 is, in my opinion, a very atraumatic wire. And here you see such a case with multiple septal collaterals. You can go safely retrograde, but you should also, in this kind of cases, be prepared with coils for the case you have perforation, because sometimes if the septal collateral is close to the apex, it could be also epicardial collateral as well. So always be prepared, check, and if you have doubt whether it is epicardial or septal, or if it's a big bleeding in the septum, you also need to coil. So we use coils. You have other options, so I prefer always to go for coils because it's the safest option. I use concerto coils because you can use it for every microcatheter, so you don't need special microcatheter. You take the same microcatheter you work with, you put the coils into that microcatheter, and it will go. This is a case of CIRC, CTO-PCI, and I tried to get from the diagonal branch to that CIRC, and you see after wiring, I checked and have seen some bleeding. So usually if you have doubt, don't tolerate that, go immediately and do balloon occlusion first, and then you have all options to think about. Maybe it will stop after a couple of minutes, but don't keep it bleeding, just stop it immediately to not get any pericardial tamponade. And you see here, after opening the vessel, before opening the vessel, I just put a coil and went to other collaterals, or maybe I did antegradely, I don't remember exactly, but if I have doubt, I put coils, stop the bleeding, and then you can also still continue working on the case and finish his case. That means having a perforation somewhere in a collateral doesn't mean you have to stop the case. You stop the bleeding and you continue if there is no tamponade or something else. So here's a second case of epicardial collateral going to the RCA, huge calcification. So in that kind of cases, I don't waste time antegradely. I try to go retrograde. It's very tortuous epicardial collateral coming from the circ. And here, again, I had some bleeding in that epicardial collateral. You see the staining, and so we don't want to tolerate bleeding, so stop it immediately. I put 1-2 coils into that epicardial collateral. I check again whether there is bleeding and continue working. You see huge calcium in that RCA, so I had to go aggressively subintimally around the calcium. And here, while knuckling distal into the PL, again, perforation, put coils, the vessel is open, and that's it. No tamponade. So it's a good message that you need always to be prepared, whether you have any bleeding, to stop it and to bring the patient safe from the table. Here's a case of, again, occlusion of the RCA. So I came retrograde, also a lot of calcium, in this case, calcification. I opened, and at the end, you see where I was in the septal, there was some staining, maybe hematoma. It's a small hematoma. If you have doubt, just put coils there, go for safety, and that's it. Intramyocardial hematoma could also happen. So this is a case of diagonal going to the circ, a lot of tortuosity going there. And I had, in this case, after externalization, opening the vessel, also some bleeding going into the septum. And also in this case, going for safety, put coils there. There was some bleeding still after coiling, but going to the ventricle. So you can check in multiple views if it goes to the ventricle, and so you can leave it. Sometimes we get also issues with bifurcations, especially if we have, if the CTO involves a bifurcation, we should try to preserve all side branches, relevant side branches, because otherwise we risk that the patients will get MI, and that would affect the long-term outcome of the patients. We use dual lumen microcatheter if you have troubles to wire the bifurcation. So this is a way, this is bifurcation of left main LAD circ. So you keep your dual lumen microcatheter at the level of the bifurcation, and you use soft wire, for example, Filda XTR, for wiring the side branch. You can also use an angulated microcatheter like Supercross if needed. And usually for complex bifurcations, I use Filda XTR, Cyan Black, Gladius. It's like escalation. And if it's needed, you can also use Gaia. If you have a flap or dissection, you need to puncture through the dissection. You can also use Gaia for that. So we need to preserve bifurcations. This is a case of a second attempt, CTO PCI, involving also the distal bifurcation. What you see here, it's a result after the last attempt. So we thought there is a channel antegrately, but this was the subintimal way from the last attempt. So, of course, you can go antegrade, try one more time. It was a mistake, in my opinion. You see here the wire came antegrade sub, and we made hematoma around the bifurcation because my wire crossed already the bifurcation subintimally. So if you keep wiring around the bifurcation, you cause hematoma, and you will lose the visibility on both vessels, so both branches. So to solve that, the only option is to go retrograde, because you will get for sure in the true lumen. Sometimes also with PCI, regular PCI, this is a case, has been done from one of my colleagues. So they had troubles to wire that OM branch. And so they created dissection while wiring the branches, and they give contrast. So you give contrast and you make the dissection larger. So once you have a dissection, you shouldn't inject, you just trust the wire, or you use IVOS, but we should stop injecting contrast because you make more hematoma and you lose more the visibility. So here you see on the right side, so it was the first wire somewhere, subintimal. We use again CTO techniques for regular PCI. You leave the wire and you try to go with parallel wiring into the true lumen. So here's a wire, the second wire, as you see, it's in the true lumen, and you can finish the case. So for more advanced CTO PCI, we should avoid subintimal rota because, in my opinion, it has a higher risk of perforations. This is a case of calcified LED CTO PCI. I managed to re-enter with IVOS and parallel techniques into the true lumen in the mid of the RCA, as you see here. And because I had friction with a microcatheter, so I decided to rotablate. As you see here, it was, I guess, 125 bore, so not a big bore at all, but it's enough sometimes that you get perforation in subintimal space. You see here, I put a stent, and it's a huge perforation. So once you have subintimal perforation, it's not only a hole, it's all the subintimal space bleeding. So it will end up with multiple cover stents. And here I guess we put 2 cover stents. We stop the bleeding, all good. But for that kind of scenario, you need to be prepared with multiple cover stents and avoid rota as well. Material loss is also a scenario which could happen. So sometimes we work too aggressively with our microcatheter, especially in the calcium. So you might lose the tip of the microcatheter, as you see here. The tip was disattached in the proximal LED. So what you can do, you leave it, you go with a wire, like parallel wiring, beside the tip, or in the tip, and you can just rotablate it with 125 or 1.5. You can push it to the side, or it will disappear here. Yeah, you see on the left side, the tip is just, so I push it with a bore and it disappears. So again, one more case. It's LED ipsilateral CTO PCI. So I came into the LED, but while pushing the microcatheter retrogradely, I also lost the tip here. And you see, I try with the wire to get into the tip antigradely, because once I get into the tip, I will be in the true lumen also, what I created from retrograde. And it was possible to do tip in that lost tip. And I just rotablate with 125 or 1.5, doesn't matter, and you can solve it that the tip will disappear. So sometimes you lose also material somewhere. So here it was the microcatheter was broken in the middle, so it was in the epicardial collateral to the RCA, and I couldn't get it out. So it was broken, and what I did, I just tripped blindly in the guiding catheter with a balloon, and I was hoping that the microcatheter is still in the guiding catheter, so tripping with a big balloon, 3.0 or 3.5, and take everything out, and I was able to get it. Regret IVOS case in CTO PCI. It's a long case. I will just try to skip it because of time. And what I want to show you, finally, regret impella case. We used to use in patients with low ejection fraction, complex CTO PCI or PCI mechanical support. We have the impella in Germany. We remember the case from Dr. Gogolus, Sevket, that the patient had also hypotonia during the CTO PCI. And I mean, if you have the impella, it will give you only safety options, especially for this kind of cheap patients. So this is a case with, after scoring the case, it was considered impella. So patient with low ejection fraction, 30% circ occlusion. I thought, okay, I will not touch the EMA, which was patent to the LED. I will go only septal to the circ and open that. As you see here, I came retrograde to the distal circ. I made tip injection to understand the anatomy of the circ. And at this point, the patient crashed down, 60 pressure and VT. So because we made ischemia for this septal. So what to do here? We had to put provisional impella, and you face a lot of calcification in the groin, as you see here. So I had to get a TAVI sheet, 18 French, put it first, and then I was able to cross with the impella. Not easy, it took like 5 to 10 minutes, but the patient was stabilized after putting the impella, and we could finish the case and take the impella out at the end. So take home message from my side: if you don't want complications, you shouldn't do PCI or CTO PCI, same for surgeons actually, and you are as good as you can manage your complications. Thank you.
Congratulations for the presentation, and I think that the last two messages were most important for the audience. So if you want to do CTOs, you should be prepared, and you should not start to do CTOs if you are not very well equipped to manage the complications.
Exactly. This is the most important message, because even if you are the best operator of the world, if you don't have equipment to solve problems, you will not be able you will have problems and lose patients.
Yeah, because the complication is just a matter of time. It always happens. Just
Yes.
even to Dr. Sianos and Dr. Gorgou. Yes.
I have two questions. First, do you have any experience about septal hematoma and how to manage septal hematoma? And the second one is sometimes I have the perforation of the septal channel into the chamber. So it's like causing the AV fistula. Do we have to close, to coil this or to close this, the perforation? Thank you.
So about the first question, if I have problems with septal hematoma, so in my experience, I never had septal hematoma because I don't tolerate bleedings in the septum as well. If I have doubt, if it's a small bleeding somewhere, we leave it, of course. But if it's like big enough, 3, 4, 5 millimeter, and you see it's get a bigger cavity by the time, so we coil it from both sides and just stop it so you can sleep better after that. But of course, if you have doubt, go for coil. And what you can do sometimes, if the hematoma is already there, to puncture. So you go there with a microcatheter and try to make connection towards the ventricle. So you take diacert and you puncture through the cavity septum to the ventricle. You can check in RO and LO. And once you create a space and connection to the ventricle, it will disappear, the hematoma. So, yeah.
The problem with septal hematoma that from time to time you cannot notice that during the procedure it happens, and I personally have two such cases when we had a septal hematoma afterwards. But we managed this conservatively. This is what I can say, and I know that Valerie have a much better experience.
There are some, George, we have done some. The issue is only if these septal hematomas are obstructing the outflow tract. That's the only issue. If this is not the case, you can leave them, and they have a very fast and effective resolution spontaneously. And what Dr. Ayub said, you can try and puncture them, but it is rarely needed, as far as I know. George?
Yeah. We had two cases together. Yes, and actually, one thing that happens is that I just want to add one thing to this. The worst septal hematomas I had with small catheters. So catheters like Caravel, when they found resistance, they buckle because the septal hematomas, the big ones, happening from lateral displacement of the collateral. Yeah, so essentially you separate it by lateral force. So the catheter is really creating a loop around the collateral because it cannot be forward. So the worse Of these, you have with smaller catheters, and actually we had 2 cases go to Kogelev. When they're too big, and we're talking about after the conclusion of the interventions, coiling is not an option. We have collaterals that they are, some hematomas that are 2 centimeters. And we had this kind of experience both times. Watch was waiting, at least for my experience, so there is, all of these are cases. Everybody can face it in a way that it is. Watch were waiting for us, and the septal hematoma is the best option. MRI was done in these 2 cases. They were in the CCU, and they did well. I had another case in Germany during live CTO meeting that we perforated the hematoma exactly as Dr. Ayud had, with a catheter in the ventricle, and it's decompressed. But I don't coil the septum personally unless it is absolutely necessary. But there is no evidence. I cannot argue that this is not the right policy or what I do is the right one. But coils into the septum are arrhythmogenic. You should keep that in mind also.
Probably an option is, if you have a choice, probably not to go too distally. I mean, distal septums are more susceptible to complications.
Okay, so
Sorry, again?
The septal perforation and causing the AV fistula to the chamber.
I didn't get the question, really.
The septal perforation into and drain into the chamber, so it's causing something like AV fistula. Do we have to close?
Usually I leave it, yes. So if it's going to the chamber, so no need. So it's very small actually. Sometimes you still keep seeing it when you bring the patient back after a couple of months. But if it's like a small one, 2 options: it's small, so not relevant, or or sometimes it's closed by itself. So I wouldn't do anything.
Just one. It's not a question, but just a statement, Dr. Ayub. As for the younger generation, what I'm always amazed, and this is the reality of it, is that in the complication sessions, especially of that, we don't see any more donor artery dissections presentations, which shows the evolution of the techniques, the evolution of the materials, and the experience of the operators. Because at the beginning of the era, the donor artery dissection, especially in the retrograde, was one of the very first things to do, and one of all of the things that amazed me during this kind of the cases is how you dissect the left main, you send the left main, you trap the microcatheter, you continue the procedure, and after recanalization you correct everything, and we are missing these cases, which shows the evolution of things. And that's a good statement on that, but it's also something that maybe we should revisit. We have a series of cases like that we should present at a certain point.
But I think the operators, the retrograde, got the reflex just to pull out the catheter when they're...
okay, so thank you everybody. It was interesting nerve hardening session because always the CTO cases which are demonstrated are spectacular. However, keep in mind that these cases are demonstrated from one of the best operators in the world. Just keep in mind.